Welcome, everyone. My name is Pam Fury, and I am System Manager of Clinical Documentation for Alameda Health Systems. Today's topic, we will be covering what is best practice for CDI in 2018 and beyond, and how can CDI further assist the physicians in documenting their diagnosis and with their clinical documentation. Healthcare today, we're going to cover this graphic here about how healthcare is practiced today and has been historically. So really, most areas of healthcare function in a silo. You have outpatient and ambulatory services and clinics that have all of their own medical staff, nursing staff, diagnostic areas, medical records, dictation systems that are not really linked to and included in the inpatient area. So they function in their own silo. And then we move to the acute care facilities of the inpatient area, and you have the same thing, their own medical staff, their own nursing staff, their own ancillary departments, their own computer systems, and they function in their silo. And then you have post-acute facilities like nursing homes, rehab centers, psychiatric centers. Same thing, own set of physicians, caregivers, software, hardware, dictation, medical records, etc. That's what we've all been accustomed to, and that's the environment that we're functioning in today, and that you're actually, quite honestly, walking into at this very moment when you come to see your patients in the hospital. What the goal is and what the challenges of healthcare in general um, in the country is across the whole healthcare spectrum, outpatient, inpatient, post-acute, is an attempt to try to decrease spending in healthcare and improve the quality of care and the outcomes for all patients, regardless of where they are in the spectrum. So we have one continuum. Just a few quick reminders for physicians that are in the audience. The AHS pillars are to provide access to patients for healthcare, to deliver quality care, and to ensure positive experiences. So most importantly, when a physician documentation properly documents all the diagnosis that the patient has, the treatment that is provided to the patient, and the outcomes achieved, the following will occur, and these are the outcomes that we're looking for. What we accomplish is the patient acuity is then properly reflected in the medical records. We will then achieve good quality outcomes for the patient care and treatment that was given. The public report cards that are accessible there to the public via the internet will reflect the care that you provided. We will likely see fewer patients expire than what was expected, and the reporting for those that expired is accurate. We will also see that patients will be allowed to stay in the hospital for the appropriate number of days to receive their care, as we can impact the allowed length of stay for a patient. And you will also find that we are paid the correct amount of money for the resources that were necessary to care for the patient. So that's what we're looking for as outcomes that we achieve when we document the proper care that we give. There are unintended consequences, however, if we do not document properly all the diagnosis, all the treatment, and all the outcomes received. And those unintended consequences are reflected below on this slide. And public report cards are typically measured with a 5-star rating, 5 being the highest star rating. And you can go online to a few different sites to determine, to look at your hospital and your own public report cards that are out there. But what is an unintended consequence? One of the unintended consequences of not having complete documentation is the observed mortality and expected mortality ratios. What happens is if it can look like what gets published, it can look like a patient that is healthy is expiring compared to all the cohort groups that we are compared to. If we don't capture all the diagnosis and the severity of illness and the risk of mortality, it appears as if the patient is healthier than they really are when you're caring for them. And it looks like that those patients that are healthy are expiring. We don't want that. That's an unintended consequence. Another one is our quality scores that get published. It looks like the quality of care that you provided is low compared to all your cohort groups. And I do know by reviewing all these records, as does my team, that the quality of care rendered here at AHS is fantastic by the physician groups. It's just that we want to make sure that it's reflected in the documentation. The other unintended consequence is the allowed length of stay. If we don't capture all the diagnosis that the patient has, it does not give the patient enough days to be treated for the diagnosis that they have. It's not the actual length of stay, it's the allowed length of stay. We absolutely want to be sure that we give the most days possible and allowed for that patient to receive treatment. Next, the severity of illness and the risk of mortality. We treat very, very ill patients here at Highland Hospital, and we want to reflect the severity of their illness and the acuity that you're treating. If we don't capture all the diagnosis, those rankings, which the highest level is a 4/4, will appear as if your patients are not very ill. They'll have a severity of illness score of 1 or 2, and it looks as if they're less ill. And we want to reflect the acuity of the care that you're providing. Also, then the relative weight and the diagnostic related group is inaccurate. And those are actually there to reflect the acuity of the patient, but that's the language and the metric that gets sent to payers. So if we don't capture all the diagnosis and the acuity of the patient and the treatments that you did and the resources that are necessary, we will be paid less from the payer, regardless of who the payer is, if we're not capturing that and showing that to them. And lastly, there is what's called a RAF score. This is something new in the last couple years, and it's called a risk adjustment score. And really, what it is it measures the burden on the healthcare resources by a patient as opposed to by an encounter. So you can have two different patients with the same diagnosis, and the reason that they were admitted, and it will appear that they have the same need for resources and risk, and they do not. And I'll just give you a very quick example. So if Pam Fury, myself, has COPD and I'm admitted to the hospital, and one of my team members also has COPD and is admitted to the hospital, but Pam Fury has a lot of comorbidities. I may have diabetes, obesity, depression, and my team member that's admitted with COPD that needs to be hospitalized only has COPD with no other history, no other comorbidities. Which of the patients do you believe with the same diagnosis and the same reason for admission will be more of a burden to the resources required to care for them? That would be myself. That would be Pam, because I have diabetic complications that need to be monitored. I have nutrition requirements from the dietitian that need to be seen, and etc. So that's where the future of healthcare is going, is to measure the actual risk adjustment score and the risk burden of any given patient, regardless if they're outpatient, acutely inpatient, or post-acute care. So let's look at the shift in the perspective. If we look in the rearview mirror and we look back from today backwards, physician documentation, really what you do is you worry about the encounter. You worry about a patient that gets admitted just for that hospitalization, just for that encounter, and we only look at the complexity of the encounter when that patient is here. And CDI is mostly inpatient based. Currently, there are many facilities that are moving it on to outpatient based as well as rehab and psych. But at AHS right now, in many places, it's still just inpatient based, and it only looks at the complexity of that encounter. We also look at just the primary diagnosis for that admission and the comorbidities and the major comorbidities that we see for that admission. With that scenario and how we look at a patient, currently we're paid based on the services that are provided. And we're paid based on how they're reimbursed by the insurer. And there's different categories of how you get reimbursed. You can get paid for your services of taking care of Pam Fury. If I was a Medicare patient, you get paid one way with all the same diagnosis I mentioned before: COPD, diabetes, obesity, depression. But if I had a different payer, like the state of California, for instance, as opposed to Medicare, we would get reimbursed based on a per day basis, which is how many days I actually use the bed in the hospital. That's today's environment, and that's how it has been historically. What's going to happen in the future? So let's think forward, and this is not in the distant future, this is in the very near future. Physician documentation is going to include and span the entire spectrum of the healthcare for that one patient. So now we're going to be looking as a patient as a whole, and we look at the patient complexity, not just the encounter complexity in the hospital. So it's how complex is this patient, whether they go to the clinic or outpatient facility or inpatient or rehab or long-term care. Yes, we will continue to look at the primary diagnosis, regardless of where they're going to outpatient or clinic or rehab. But what we start to look at, in addition to the comorbidities and the major comorbidities, is something called an HCC. And that is the measurement of the risk score of that given patient. It stands for hierarchical category condition. So moving down to how we get paid when we start to look at healthcare in this manner, instead of being paid on services provided, we will be paid on quality models and quality outcomes. So capitation is the most well-known one. So there's two payers that you'll be familiar with that pay in this manner. One is Kaiser. Kaiser is paid on a capitation model, and I'll go through that in just a moment. And also then there is Medicare managed care, and not Medicare Part A. Medicare managed care is also paid on a capitation model, and at AHS we currently have 35,000 outpatients that are actually under that payment model. So the way that they pay is they pay as a dollar amount per member per month. So what they do is it's kind of like insurance actuarial tables. They look at everybody who has that insurer. Let's just take Medicare Advantage or Medicare Managed Care, and let's just say that they have 10,000 members that are patients of the whole Highland healthcare system. They look at the risk of each of those patients, and you could have myself, which has a high risk score, and you could have many other people which have a lower risk score because they don't have a lot of comorbidities, or HCCs, categories of risk, and you get charged a certain amount per member, and that's how you get reimbursed. So anytime a patient gets admitted, you get reimbursed based on a per member per month fee. So an HCC that gets documented, regardless of outpatient, inpatient, or acute, an HCC has to get documented. That then results in a risk score, which then results in the dollar amount that you get reimbursed on a per member per month basis. That is the Kaiser model. So here's the continuum. I just want you to be aware that there is an overlap between these HCCs, but there's only 79 hierarchical care conditions right now, or hierarchical condition categories currently. There are tens of thousands of comorbidities. Um, like all of the chronic conditions that you document, in any diagnosis falls into a comorbidity or a major comorbidity. But there is an overlap of those HCC categories to measure the risk care of a patient to the comorbidities of a patient. HCCs and risk adjustment. I just want you to understand, again, now this is not by the encounter that a patient comes into an acute care setting. This is by the patient complexity. So an HCC are groups of a diagnosis that will predict cost based on the disease and demographic risks of a given patient. The patient the patient complexity and the risks are all interrelated to quality outcomes and to those capitated payments. There are 79 codes for active and chronic conditions with some CCs and MCC overlap. Each of those 79 HCC codes has a weight, and that weight is used to predict the patient risk score, that RAF. The patient risk score then determines the amount of resources needed to care for that patient. Again, compare patient Pam with another patient that comes in with the same symptoms to the ER, shortness of breath, and the same admitting diagnosis of COPD, acute exacerbation, but their resources needed to care for them is really dependent on any other comorbidities and risk factors they may have. So payments to the provider, whether it's the hospital or a physician, are adjusted to reflect the complexity of that patient in its entirety and their payments. In order to ensure a proper risk score and payment, the HCCs that are documented must be updated annually. And if anybody ever wants that list, I'd be happy to send it to them. If it's not updated annually, then the payment drops to a small risk score and risk factor. And I'll just give you an example. Diabetes. I might be diagnosed with diabetes this year, but next year I might have diabetes with complications. And my complications might include I now need dialysis, or I might have neuropathy, or I might have vision problems. If it's not updated to either reflect what they currently had or change the severity of that HCC, like diabetes, then it will just assume the lowest risk score and the lowest reimbursement. So that is how the spectrum of healthcare is coming together from outpatient all the way through the inpatient and post-acute state. The methodology that applies to all risk contracts such as Medicare Advantage or Medicare ACO, that will alter the per member per month payment. The number of people enrolled in these capitated type programs is expected to double by 2025. So that's really only in 6 to 7 years. So this is coming upon us very quickly. Now I just want to share with you the evolution of documentation tools so that you understand as new tools come out what they're really doing for you, and they are aids to make it easier for you to document your medical record. So just in general, there's hardware tools, right? There's dictaphones for you to dictate, there's typing, regardless of where you type, there's computers, there's the mobile phone. That's hardware. Embedded in all those components of hardware are software tools. There's software to enable the transcription. There's software on the computer for your EHR, whether it's Epic, whether it's Cerner, whether it's Meditech. There's software for case management. There's software for utilization review. There's software for quality assurance. There's software for clinical documentation. There's software for coding, and there's software for reimbursement. So there's many different types of software that are there as tools for documentation that are embedded into the hardware. What's really new are these intelligence tools. So you all have heard of artificial intelligence. Well, the intelligence tools are really back-end logic that ancillary departments use, such as coding. If you've ever heard of computer-assisted coding, it's an intelligent tool that sits on the back end. It's referred to as CAC, and it goes over a document to read the actual language that's there and help the coders code. So it'll pick up CHF and it'll look, well, CHF was documented 16 times in the medical record. It must be a diagnosis, and it helps them put that on the coding list. Then there are human tools that help you. That would be us, the clinical documentation specialists. It would be continuing education sessions. It would be quality assurance reviews, coder reviews, and actually scribes. Those are all human tools that we have right now that can assist us and help you with your documentation. The newest of the new that will be coming out are intelligent tools that occur at the physician point of service. It's very, very important. So as you're providing your care and dictating your notes, these are new intelligent tools that will help you. So they're engines that will process your language as you're speaking, and it's physician's natural language. There's two types. There's called NLP and NLU. NLP is natural language processing. What that means is this artificial intelligence that's on the back end while you're dictating and or while you're typing your note. They might recognize a word and recommend a more accurate word. So for instance, they may recognize congestive heart failure and further know, because of the intelligence, that you did not indicate systolic or diastolic, so it will prompt you to add the systolic or diastolic. Very terrific. And there are a few companies out there that have NLP that get embedded into your EMR when you're into your dictation tools when you're dictating and or you're typing in your notes. What's more advanced than NLP is NLU. NLU is natural language understanding. The difference between the two is NLU is much more advanced. It hears a word, and it might hear the word appendicitis. And what it does is it can read everything across the medical record, include not just what you're dictating and what you're typing as a physician, but it reasons over the lab results, the x-ray results, any other radiology reports, and can recognize symptoms that are documented in your medical record. Then it can recommend an improved diagnosis or an additional diagnosis. So that's really, really artificial intelligence that augments the human intelligence as the CDI can do. Perfect example of this is a patient's admitted to the ED with appendicitis. They end up going to the OR for surgery, but their white count is high. The radiology reports might indicate something. The patient, you have been documenting or dictating rebound tenderness. So, with natural language understanding, the artificial intelligence would say, "Dear doctor, could the patient perhaps have peritonitis, localized or diffuse peritonitis?" So it is very intelligent and can reason over the document. And honestly, that is what CDI does currently today. When we review a medical record, we review every document in the medical record and don't just look for the accuracy of how a diagnosis is documented, but look for clinical evidence for other diagnoses that could also be documented in addition to what you've already put. So NLU can reason over clinical evidence throughout the medical record. Then lastly, there's an integration of this hardware, software, and intelligence tools with a new EHR. So at AHS, we're going to be moving to Epic. And the EHR does require an intelligent engine that is embedded from a third-party payer because that's how the most advanced EHRs are moving to include NLU or NLP. So that engine provides physician documentation and assistance at the point of dictation, as well as at the point of your note writing, as well as your final signatures. You've heard probably the acronym CAPD. That's called Computer Assisted Documentation. Computer Assisted Physician Documentation, CAPD. So you will have Computer Assisted Physician Documentation. The engine also provides the physician documentation assistance in capturing of the CCs, the MCCs, and the HCCs throughout that healthcare spectrum of outpatient, inpatient, and long-term care. This slide will quickly just give you an overview of how CDI can help progress along with the physicians in this new approach to clinical documentation. So currently, we're doing a good job. You all are doing a great job by doing just basic CDI on the inpatient side, looking at capturing the acuity, the severity of illness, allowed length of stay, DRG, per diem reimbursement, and case mix index capturing. And we're doing that very well. We're probably covering anywhere from 50 to 60% of all the eligible patients currently at Alameda Health Systems at all 3 acute care hospitals. What we can continue to do with a little bit of expansion of the department is what are called mortality reviews. So within 30 days of a patient expiring, CDI can review that medical record to make sure that it's maximized and totally reflects the expired patient's severity of illness and their risk of mortality. That will then improve that published report card because we will truly reflect the severity of illness and the risk of mortality, and it will improve the perceived quality of care that are reported to the public. And then it just prepares us for the pay for performance and the hospital-based value purchasing payment cycles that are coming up in the near future. And then we can move even beyond that and apply CDI in an outpatient setting so we can capture that risk I was telling you about. So if we can put some of those software tools in the outpatient setting, those same patients are become inpatients for you. And if we capture the proper risk in the beginning in the HCCs, and again, we maximize the patient's severity of illness, we maximize their risk of mortality scores. We also can capture their RAF score, improve the published report cards, the quality of care. And that would require implementing an entire program like we have inpatient into the outpatient center. But hopefully we'll be able to do that in the next couple of years that will assist you. I'm now going to show you a video that was recorded by Dr. Chris Albin of Epic on how an NLU is integrated into the electronic medical record. After the videos, this will conclude our presentation, and I thank you all for attending.
Hi everyone, this is Christopher Albin, one of the physicians on the team at Epic, and I'm just going to give you a quick demonstration of how M-Modal's tools work with note reader CDI, specifically the natural language understanding component behind the Epic note reader CDI capability. So I've logged in as Dr. Walker, and I'm taking care of a couple patients, notably Mr. Knight, as you see on my patient list. Now, he's been in for a couple days. I've got my H&P done, and he's done okay, but I expect that some of the note reader CDI elements are going to update me. And in part, I get that indication right in my patient list, letting me know, hey, there's some new queries. And just launching into his chart right from here will let me know what those are. Now, I've got actually one from Sam Burris in our HIM department. That's one of those manual ones. They all go to the same place because the M-modal note reader CDI queries also come there as well. And so that's great. This gives me an opportunity to act on them as I jump into my progress note. Now, I don't have to look at those first. Just they come in automatically right into my note writing process. So as I go to notes and do his progress note for today, maybe I'll just bring yesterday's note forward using our copy previous notes and update the links accordingly. That's great. But as you see that note forward, and I'll begin to update and edit that, there's an indication right in line there that there are some items that I might want to address to take care of those potentially missing CDI type elements that would be great to take care of. They address our case mix index, they address billing. There's all sorts of benefits that come from doing this. And if I take care of them now while I'm doing my note, I don't get those calls from HIM later on that always interrupt me. So it's a nice way to be able to take care of that and address those things pretty easily. Now, it gives me the reasons why, all the supporting evidence as a part of these. There's a couple of them. Apparently, there's evidence in the chart for MRSA pneumonia, as well as one for indicating shock. That's an interesting point. We certainly need a document. And the rationale, where did I document previously that is supporting this is part of this. Whether it was me or anyone else who put a note on the chart, we'll see that information and how that might support this specific, the decision support that M-modal was factoring in. What happened was we wrote these notes. Every time I finish a note, whether I sign or pen, the data stream goes off, they do the crunching, and that comes back as an asynchronous stream back into the chart, just waiting for one of us to take care of it. I don't need to get alerted outside of that, but it happens nicely right within line, and I can take care of those as I go through and do my documentation. So great. There's the supporting evidence for the indication of MRSA pneumonia. Likewise, the mention in my progress note from yesterday as well certainly makes sense. The nice part that makes this easy is, if I want to add that directly in there, a comment about that pneumonia, for example, I'll just hit that link and it'll drop that line right in my note as the documentation. And of course, as soon as this is done, this data feed goes back off to M-modal. They do their crunching and they'll update with any new information that might need to be addressed. Now, I've taken care of that first one with a little, you see the check mark there. Let's take a quick look at the second alert indicating we should say something about sepsis. Apparently, he's got criteria. We've been treating him all along, but putting that diagnosis of sepsis on his chart is probably an important thing to do. And certainly, the HIM and the CDI alerts help me do that correctly. So that's great. I'll put those on there, and let me just drop that quick note right in here as an additional diagnosis. Simple to click that link, drop the note in, and I've taken care of everything. I've got 2 blue check marks all taken care of. I'm all set to go. I'll finish up the rest of my note and proceed from here. So that's great. I've got Mr. Knight all taken care of, and I'll proceed on with any further documentation and care of him. Now, you might want to take a quick, you might wonder, how does this look to the CDI folks? Let's just jump over to them for a second. I'm going to jump over to that chart and take a look at how his account looks to our CDI folks. I've logged in as Sam Buress, who's looking at his account and all the core tools there. Those queries, whether we create those in HIM ourselves, as you see with that first one, or whether there are specific queries that M-modal is sent across, I have one center, one location where I get to review those, which is nice. So while those manual and the automated really work very well together. And as I see the clinical sepsis one, there's Dr. Walker. He agreed with it. He put the documentation in his chart. I get those details right here. That allows me to keep track of how things are going. And really, my manual follow-ups become where things might have gotten missed. I need to talk to a particular doc who might have missed something, that sort of thing. So this gives me that nice central location to review all of the clinical records, as well as those sorts of CDI-oriented decision support that are certainly important to making sure our charts are not only clinically effective, but also from a compliance and and billing and other factors, really all those elements are covered. Okay, I'll wrap right there. Just a quick brief overview. And if you have any questions, contact your Epic TS representative or the folks from M-Modal. They'll be happy to talk more about this with you and work things out.
This next video will demonstrate how we capture an HCC in the outpatient setting that will eventually assist you as physicians in the inpatient setting.
Hello, this is a quick video showing our latest HCC management application functionality. I'm in my fake EHR, and right when I jump into my patient chart, you'll notice that CAPD shows me an HCC engaged summary about outstanding diagnoses not yet captured for this patient in a claim. It's really important that you make sure all the risk adjustment diagnoses are documented and fully specified and included in a claim, and you're going to see here how our technology helps to do that. First, of being shown is that they're suspected diagnoses. This means that they're found by our natural language understanding in the documentation. So these are, again, things that never made it onto a claim, meaning they're never being captured for risk adjustment. One of them is major depression, and then also type 2 diabetes with neuropathy. You can see that the physician has billed for diabetes without complication this year already, but that's not good enough. This is not the right code for this patient, and it's going to have a significant impact on risk adjustment. So when I jump into my clinical document, I can edit the draft that I started, and you'll see I can continue to dictate or type, and CAPD will update and continue to show me relevant feedback. I am able to get CDI engaged messages along with my HCC summary, and I can use my actions as normal. For instance, I can specify atrial fibrillation as chronic to make sure that the ICD-10 code we bill for is going to be completely fully specified, so that unspecified AFib changes to chronic AFib. But again, just having it documented is not good enough. You'll see that I'm missing supporting evidence. I don't have that meet criteria yet. So let's go ahead and make sure we get that captured. Morbidly obese period, new line. So again, CDI engaged suggesting I document obesity based on her vitals that I pulled in here. You'll see then that message resolves, and now I can bill for her being morbidly obese. This includes all the meet criteria. But for diabetes with this complication, I didn't yet specify that. So what I can do is I can click right on it, I can insert that into my document, making it easy to make sure I get the diagnosis in there, and now I have a field I can navigate to fill in the relevant care plan. Not currently well controlled, A1C 8.2, period. We would like to work on lowering to 7 period. She needs to follow up with a neurologist about foot numbness and a nutritionist for diet and exercise plan review, period. So I got my diabetes fully specified because I have a care plan in there, and I said what we're going to help follow up on. You'll see that this is now appropriate to bill for that high-level condition. It'll go into my risk adjustment, and I can do the same for the remaining diagnoses. Really fast, let me show you what the Collaborate side looks like. If I open up my web-based application here, you see I'm already inside of that same patient. And for this Kate Molinaro, when the reviewer is looking at her history, you're seeing all the outstanding diagnoses that are not in a claim yet this year. And these two diagnoses, type 2 diabetes with neuropathy and this depression, have a little bell next to it because they're included in the provider notification that was shown to me. So that real-time message I received came based on the conditions I have configured for this patient. You'll notice, though, that there are some diagnoses that were billed for this year. As I mentioned, the diabetes without complication. You see that the patient used to have uncontrolled diabetes with no other complications, and the physician just continued to use the same code year over year. A very common thing, but unfortunately it doesn't help capture the risk score, and you see that diabetes with neuropathy is 3 times the value. So hopefully, if I finish my document and bill appropriately, you'll see this get checked off, just like our unstable angina did. This diagnosis was documented and billed for this calendar year, so we're all compliant, and our goal is to help make sure that all the appropriate conditions are captured in the same way. Over time, as we close the gap on this patient, you'll see that my work list will reflect that, and here we're having it prioritized based on all the outstanding gaps so that your organization knows who to focus on and making sure they're bringing in those valuable patients first.